Well, hello everyone. My name is Dr. Raven Baxter, and I am your host of this episode of the Raise the Line podcast. I'm a molecular biologist and director of science communication at the Cohen Center for Recovery from Complex Chronic Illness at the Icahn School of Medicine at Mount Sinai Hospital. And at the center, we work to advance treatment and knowledge of long COVID, tick-borne and vector-borne illness, myalgic encephalomyelitis, chronic fatigue syndrome, and connective tissue disorders like hypermobile Ehlers-Danlos syndrome. And this series is on post-acute infection syndromes. And those are characterized by persistent symptoms that last for months or even years after the initial infection has occurred or has been treated. And although we are still developing our understanding of clinical manifestations and treatment pathways for these conditions, there's still much progress to be made. And so, with that being said, I'm excited to speak with three distinguished guests, each bringing their own wealth of knowledge and experience from their specialized fields. And today we'll be discussing the clinical manifestations of post-acute infection syndromes within the context of mast cell activation syndrome, or MCAS, and also joint hypermobility and joint pain. So together, we're going to illuminate some insights and hopefully provide some good tips and information for you to work through in your own practice. So yes, I would like to begin by each of you sharing a little bit about yourself and what you do and how you came into your field. I'm going to start with you, Val.
Great. Well, hi. Thanks for the introduction, Raven. My name is Valerie Irvine Rogers. I'm a physical therapist, and I primarily treat patients that have joint hypermobility and issues associated with that. Joint hypermobility is typically not traveling by itself. So that's where I fit into all of Raven's introduction of the common comorbid signs and symptoms of things like mast cell activation syndrome and the other effects that can happen with the post-acute infection syndrome. I now work as a physical therapist and also as a researcher and an educator with Mount Sinai, working alongside Raven at Cohen Center for Complex Chronic Illnesses, all with that drive, with that focus of hypermobility.
Thank you, Val. Dr. Maitland?
Ooh, that's a tough act to follow. So I am an allergy immunology specialist, and I split my time as a super commuter between as an assistant professor at Mount Sinai in the Department of Medicine, Division of Allergy and Clinical Immunology, and I'm also the director of Allergy and Immunology Services at a new Neuroimmunology Institute in Salt Lake City. The past decade, I had to relearn all about the innate immune system, including mast cell disease, because it's not well taught. And interestingly enough, how I find that one major infection, SARS-CoV-2, kind of ripped the Band-Aid off of us trying to learn the intricate communications between our nervous system, the immune system, the connective tissue, as we take a breath, take a bite, or just try to move without much pain and difficulty.
And Eileen, actually, how would you all like to be referred to?
I'm fine with Eileen. My name is Eileen Ruhoy. I am a neurologist, and I also have a PhD in environmental toxicology. And so I've always sort of been fascinated with how our environment and our exposures contribute to our health and or lack of health, our disease. And so I am the medical director of the Chiari EDS Center at Mount Sinai, South Nassau. And, over the years, I've really dived into the connective tissue component to chronic illness. And so many of these patients with chronic fatiguing illnesses in the post-infectious space present with connective tissue dysfunction or disorders. And we see a lot of patients that have hypermobility for sure, hypermobility type EDS. But sometimes the hypermobility is not as obvious as you would like it to be with regards to the Baton scale, for example. And there's a lot of spinal manifestations, a lot of neurological manifestations. So they present in a very much a neurological phenotype. So that has always been of great interest to me. And that is sort of where I, over the past decade, sort of have led my career. And so I now, see myself really just sort of in this niche of connective tissue and its role in chronic disease.
Thank you. I would like to talk about how you receive patients. So For some of the professionals I've spoken with, for example, Dr. Shannon Delaney, she specializes in neuropsychiatric treatment of patients who have chronic Lyme disease. And so by the time she sees a patient, they already know that they've had Lyme disease or they were bitten by a tick and something changed. But how do you receive patients? Do people often know what's going on when they come to you, or is there a process that you have to go through to figure out what the root of their issues?
Well, I'll answer that first. Yeah, I mean, I'll just dive in. I guess we can all just interrupt one another. I'm perfectly fine with being interrupted, by the way, guys. So feel free. But usually by the time I'm seeing a patient, they've seen lots of doctors who have basically not given them a diagnosis or have not been able to understand what's been going on with the patient in order to help guide their treatment and management. And so I just sort of listen to the patient's symptoms, and I do a fairly comprehensive workup. I meet them where they are, and then we go from there. I try to figure out why they're having particular, set of symptoms. If related to, like you said, like a tick exposure, for example, then we go down a tick-borne disease road, and we do a lot of testing, and we find the reasons for it. But I always think about the immune system and how the immune system responds to each and every exposure, whether it's an infectious exposure or a contaminant or a toxicant. It could even just be a fragrance. There's an immune response to just about everything we're exposed to. And so with regards to the history of the patient, of which I take a very extensive history, again, about their exposures, I think about the immune response and the inflammatory response. And that's where I sort of start to try to figure out what's going on with them. And like I said, I do a very comprehensive workup, which includes labs and imaging, a full neurological examination. And then I just sort of come up with, based on what I find, I come up with a plausible idea of what might be going on. And then I empirically try some things, and based on how they respond, whether positive or negative, I make the next decision. So it's a lot of back and forth between me and the patient. It's a lot of communication. It's a lot of trial and error. I wish there were blueprints and roadmaps and algorithms for us to follow. But in the chronic and complex world, as I'm sure Valerie and Anne will attest to, there isn't that nice protocol that we have in medicine, like, A means B and B means C and therefore D. We wish it were that simple, but it's not. So it takes a lot of time on our part. It takes a lot of listening. And it takes a lot of just sort of putting pieces of a puzzle together. So I work really hard with patients and trying to figure out what's going on so that I can best help them.
I would have to say that both Eileen's comments and Raven, your question points to the problem with our healthcare system that really doesn't allow a conversation for patients to address multi-organ system involvement. And also I find that patients have a tendency to focus on what bothers them the most, as opposed to other signs and symptoms, which might point clues to a more global issue involving that neuroimmune axis operating within the connective tissue. And so generally speaking, there's only one immunology specialist for 100,000 residents in this country. So I would have to say a lot of practitioners don't even know how to refer to an allergy immunology specialist. And so by the time a patient even comes my way, for instance, I, like Eileen, I need at least an hour after they've completed an 18-page questionnaire to try to kind of distill down what are pertinent signs and symptoms to kind of steer me by, what potential exposure. And I even push back on even certain diagnoses such as Lyme, because not everybody who gets exposed to that bite will develop Lyme disease. So what about that individual's system allowed them to develop this type of a chronic disorder? And I think we just can't stop at the exposure, but what does that person bring to that encounter that led to that outcome? We saw that with, for instance, SARS-CoV-2, where children were untouched, essentially. It was a near death sentence for over 65. And then one through 4, between 18 and 65, either were untouched or were deathly ill. And so I think we have to understand the dance between the individual with the environmental exposures that would lead to such a chronic issue. And then also because we don't recognize that this is multi-organ system involvement, and a lot of practitioners have a tendency to stay in their corner of the sandbox, we find that these individuals end up going to specialist after specialist after specialist, back to the GP who sends them to another specialist, who doesn't take a step back and say, okay, what we know that individuals that have chronic upper airway inflammation end up having lower airway inflammation. And gastrointestinal distress can be associated with musculoskeletal issues. And so every part of the body talks to each other. So we, in many ways, I think all of us are generalists with a specialist eye. And I think we need to understand what part of our experiences may be more forward in that patient, or what might be our specialty that might be responding to the initial insult, or how the person kind of deteriorated into this chronic state of debility from the initial exposures.
I'm in a unique position. I feel like I'm actually kind of lucky where I get to receive my patients. So people are coming to me as a physical therapist because they have joint pain. And with me specifically, a lot of times they're seeking me out because they know they're hypermobile. They might not know they have a formal diagnosis of hypermobile Ehlers-Danlos syndrome. They may meet the diagnostic criteria, or they may not. But having pain and having hypermobility, I feel like I can play a role to really help them manage that condition, whether they meet that criteria checklist or they don't. What's nice about my role is that they're coming to me with this joint pain. And the joint pain is clear-cut, as in they came to the right person, I can help with this. What's less clear-cut are the miscellaneous symptoms that usually accompany a hypermobile syndrome. So both in Eileen and Anne's case, they're usually seeing these patients after many, many, many specialists, and they finally have someone that pointed them in the direction, you've got to go see this person. They're the best of the best for this rare complication that you may have. And they might say, I've been dizzy, and someone told me it was POT, someone told me it was CCI, someone told me it was all these other issues. And they have to trickle down the whole medical system to reach someone like Anne and Eileen. So I love being in the physical therapy standpoint for someone who has a hypermobile condition, because I get to kind of ask these questions that I know that these people are predisposed to. And I could say, that sounds a lot like mast cell activation syndrome. Let's get you over to someone like Dr. Maitland. That sounds a lot like one of the many neurological complications that come alongside these hypermobile conditions. Let's get you over to Dr. Ruhoy. And then the hope is, if Dr. Ruhoy finds that they may have craniocervical instability or atlantoaxial instability, but she thinks that it's a safe enough threshold that you can treat it conservatively, she'll refer back over to me, and we can address those things. We can address the stability and the proprioception that might be impacted. And that way, it really harps on the importance of an interdisciplinary care team where all of us kind of have to work together and communicate with one another, and communicate and educate the patient enough that they need to know what they're advocating for, where they need to go, and how to manage their other symptoms, because all of them are so interconnected.
Teamwork.
Yeah, for sure. Well said, Valerie.
Yes. Yeah, I thank you so much for sharing. I would like to get into some of the flags that might come up when you are consulting with a patient about their experiences. I could take my own experience, for example. I have long COVID, and I would say I'm really far down the path of recovery. But initially, I was very severely ill and bedridden. But the reason why I was bedridden was because I couldn't move without my throat closing up. And so I was like, well, maybe I just should stop moving so that I can breathe. And I said, I feel like I'm allergic to moving. And I was trying to explain that to people, and they're like, girl, what are you talking about? That's crazy. Like, you're losing it, right? And I'm like, no, you don't understand. You don't feel what I feel. And so, I explained that to my doctor, and he said, oh, you have generalized anxiety disorder. Yeah. And so that went on my record. Interestingly enough, he said in my record, it says, like general anxiety disorder caused by COVID-19, which is interesting that he wrote that. So, I would like to hear from you all. When you have a patient in your room, how do you listen to the patient? What are some things that should signal to you, hey, this is something we should dig deeper on, and I shouldn't dismiss this as X, but rather look into Y or Z or ABC?
Well, Reagan, what you just did was really powerful. You shared your experience with us. And that speaks volumes to you as a person, you as a professional, and you as a patient. And I actually find a lot of success doing the same thing with patients as well. I'm actually a provider in this field, of course, but I'm a patient as well. And I deal with a lot of these things too. So relating to these patients is helpful to kind of get them to open up like, hey, I believe you, I trust you, but you certainly don't need these things to connect with your patients. You can connect with your patient without being a patient too. And so it's saying, I hear you, I believe you, these things are real, this is not in your head. That's actually one of my lines in my evaluation. I almost always say to somebody, this is not in your head, you are not crazy, you are not making this up. Please tell me more about what you're talking about. And one of my rules of thumb is that I never cut a patient off. I let them talk and talk and talk. And if we have to get to physical exam or more exercise in another visit, that's what we'll do. But that was very productive for them to open up and share the whole thing, because so often patients will do exactly what the medical system encourages them to do and break their symptoms up into, well, I think this goes with my physical therapist, so I'll tell her about this, but I think this goes with my neurologist because this seems more associated with that, and I won't get all of the communication. So I agree with what you're saying. It's very important to encourage people to tell the whole story. And similar to your experience, it's very important to educate patients, to have them to understand the difference between, so often you hear exercise intolerance when you hear these conditions. People will say you have exercise intolerance. And I really like to challenge that phrasing. It's not necessarily exercise intolerance, but appropriate dosing of exercise. So in that phase, Raven, where you were bedridden, maybe the right thing for you to do in bed would have been some exercises, some breathing exercises on your back. And that's it. But that's still something to be proud that you're doing, that you're working towards, and something that's very worthwhile that'll help you get to that next step.
I would echo what Valerie said with giving the opportunity for the patient to tell their story. But I think also I think every patient needs to learn how to tell that story. And this is kind of where having targeted questions to let people take a step back and say, you know what, I actually do have problems sleeping. Or, I've always not made an effort to, when I was in elementary school, I could swim like a fish, but I can't run long distance. Or every time I start exercising, I start getting itchy. There are, and people will acclimate down to what their body lets them do. And so by the time you see them, they're actually quite debilitated. And so then it's like, peeling the layers of an onion back a little by little. But also I also led to the opportunity to have multiple visits. And also I tell the patient, look, I'm not going anywhere. I'm not afraid about what you're trying to tell me. And I've been humbled by patients in the past saying, if I don't know, I have to say that I'm comfortable in saying I don't know, but that doesn't mean I'm not going to keep on trying to investigate how I could potentially help. And then also, I think because we've all been on the other side of the bedpan to appreciate what it's like to be a patient, we also lay the table so someone is comfortable enough to share things about, well, you know what, actually my mood is impacted. You could have a mood disorder in the setting of a general medical condition. So, to rephrase, Raven, what you were given, I would have said you may have had a mood disorder in the setting of a general medical condition as opposed to just labeling it an anxiety disorder. And I think because, our respective trainings have been so siloed. Like I had, 3 weeks of psychiatry and mental health training, third year of medical school. I think a lot of us I think psychiatrists have a tendency or mental health experts have a tendency to dismiss somatic complaints. And I think people who focus on different somatic complaints, or practitioners who focus on different somatic complaints, really don't know what to do with mental health components. And then will default to giving medications to kind of control those symptoms as opposed to digging down a little bit deeper and saying, you know what, I believe you. And I tell patients, I say, use this with me. When we're after we finish talking, do I have an idea about what might be going on with you? What can I do to help you feel better as I'm peeling back that onion regarding what I think might be going on with you? What potential side effects, whether it's exercise, supplements, medications, what are the potential side effects from that? What tests am I going to order to try to figure out, or assessment that I need to do to figure out what's going on with you? And when are you going to come back? And that's the most important thing, is when can you come back so we can continue digging into that story and building that practitioner-patient relationship so that there's a trust in there that I'm going to listen and I'm going to give you whatever information. And by the way, every person who leaves a visit ends up with, I think, patient-friendly literature or patient-friendly video tools, because people learn differently, so that they have more resources besides just my little office that is looking over a beautiful mountain range. But so I really think this has to be a multimodal approach. And then here's the thing, Valerie, Eileen, we all know who to refer to, right? But we also have to start teaching others.
Yeah, I mean, our referral network is too small, right? I mean, I think we'd all agree. Yeah, it's too tight and too small. We need more.
And we need to, and I think the three things that we really need to do is start getting in early into like medical systems like Mount Sinai, and start teaching medical students early on how to take a good history, not to dismiss the patient because you can't figure out what's going on. And then who else can you bring in to help with that discussion? And I think, again, having a multidiscipline center like the program that's being coordinated at Mount Sinai, I think is unfortunately a rare occurrence in our healthcare systems today. And we really need to make an effort not only to improve the education, improve the resources, but also because, a 6-month wait to see any of us is not going to be helpful for anyone.
Yeah, I agree. And I mean, I don't have much to add. I think Valerie and Anne really sort of covered the question. I just also will just reiterate that I feel very strongly about letting a patient tell their story and listening to the details of what they're trying to tell me. And I will sometimes intervene with a very pointed, targeted question. What I've learned over the years, I do a lot of, I trained in both pediatric and adult neurology. So I learned in my pediatric years that children have their own vocabulary sometimes when they're trying to explain a particular symptom. And so it would take a little bit of an effort on my part to really understand what they were experiencing. And I sort of apply that to my complex patients because they all have different verbiage to just basically describe sometimes a similar symptom. And so I listen hard. I listen to the words that they use. In fact, some of the questions that we've included on our questionnaire at the Chiari EDS Center really do refer to some of the words that a lot of patients will use with regards to specifically a diagnosis like CCI. Things like bobblehead. I can't feel it. I can't keep my head on top of my neck. So they have interesting ways of describing what they're experiencing, and that does not take away from the symptom, the disability, the discomfort, and how it's impacted their lives. So I feel strongly about listening to their words, but I'll also sometimes sort of add a targeted question. So I, largely for my purposes, so that I'm sure that I'm following them and that we're on the right track. So it is important to really have an engagement with the patient that is fruitful and therapeutic. And I agree, sometimes if I have to take a lot longer just to have that conversation with them, and then we decide that we're going to do more the next visit, then that's what we'll do, because I really don't like to cut patients off. I really also do not like having them leave feeling like I didn't understand, that they were invalidated, that they were dismissed, that they were gaslit is the word that many will use. I'm sure we've all heard that word. I know when I was a patient, I was very dismissed. So it's not a good feeling. It just isn't. And so anyway, I do take a lot of time to be sure that the patient feels at least validated. And I agree with what Anne was referring to. We need a larger network. I mean, so yes, I have like a handful of people that I refer to, but they have huge waiting lists, and I always say PT is a cornerstone of your therapy. I mean, I literally must say physical therapy like 40 times a day. Like, this is what my EDS patients need, but we don't have enough physical therapists who are as competent as Valerie is, who really understand an EDS body. And we need Valerie to go out there and just do like a tour across the country and train other PTs. But and we need immunologists like Ann Malin. I mean, my gosh, like, I don't know who else to refer to if it was Ann. So honestly, we really need to do a lot of education. We need to disseminate information. And, I know that, Ann and I have had these conversations before about how we go about specifically doing that. And I agree. I think that the curriculum that's being designed at Mount Sinai, especially at the Icahn School of Medicine, is a really great first step and something that we're super excited about. But it's just so necessary.
Thank you. Okay, so I want to pivot a little bit and do something that I feel like will be very intriguing, and that is find that overlap in this Venn diagram of post-acute infection syndromes, joint hypermobility disorders, and I guess mast cell activation syndrome. Is there an overlap between all three of these? Let's talk about it. I want to get into this.
Why don't we just talk about the basics of how our body operates? And if you think about the three organ systems that are represented in every part of our body, you're talking about the connective tissue, elements of the nervous system, and elements of the immune system. And unfortunately, the one component in the immune system that's represented in every part of the connective tissue is the mast cell. And so you have to, and unfortunately, this cell that was identified back in the 1800s really didn't get a job until 1989. And ever since then, it's been, as many people do, they misprofile this cell to say that it's the bad guy in this. But in general speaking, just like I think the muscles, and I'll leave Valerie to answer that question, if you have loose ligaments, your muscles might be compensating for those loose ligaments. If you have other components of your immune system or of the neuroimmune axis that might not be up to par or missing, guess what the mast cells will do? They will go in and compensate the best their job, because their job is a first responder. So really, you're looking at the connective tissue, and in adults, you're talking about 75 square feet of connective tissue that's exposed to the environment, that your body has to make a decision of everything that's coming in, toxicant-wise, temperature-wise, and not all bacteria and viruses are dangerous. So you have to make a decision, kind of like the poor TSA agents at JFK, and I can testify that was good. Your body has to make a decision, safe or not safe. And so I really think, and I kind of, and Eileen and Valerie, you can say I'm off base, but I really treat it as a triad of how our bodies are dealing with the encounter of moment to moment, and what resources do we have to deal with that encounter, and a plethora of encounters on a moment to moment basis. And so I think we can start just on the fact that nerves and mast cells talk to each other all the time within the connective tissue.
That's actually a great way of putting it. That one last sentence is sort of just the synopsis of what is going on physiologically. That is very true, that communication.
Yeah, absolutely. I agree. And something I use a lot of times to educate my patients about why they get stuck in this circle of a triad here is that, your autonomic nervous system, its structure is made of connective tissue. And what does your autonomic nervous system do? It teaches your immune system what to do. And where does it do that? In the connective tissue. So what are the chances that if you have an issue with one, it's not going to feed back into the others? And who's the culprit? That's a great question. I am actually a firm believer, and I think this is a place where research absolutely needs to be called for, but that's where this post-acute infection syndrome can really tie in here. Is you might see somebody, they have a touch of hypermobility, and they're okay. And that's one of the phrasings that actually drives me crazy, is when people say just hypermobile, because being hypermobile leads to so much, and being hypermobile alone is so much to handle. You have all that joint play from the lack of the passive subsystem, and that's going to be causing so much friction on the joint surfaces that they're not made for, and cause that early onset of osteoarthritis. You have this predisposition to subluxations, those partial dislocations and real dislocations as well. and both of them very painful, in addition to the osteoarthritis. So now we're dealing with all these hypermobile issues, but keeping in mind what else it comes with too. So their connective tissue is poor. They're probably going to have some issues with the autonomic nervous system. They're probably going to have some issues with the mast cells. And so I always open with a bit of education to help the patient really understand why it's not just stabilization that's going to be the key here. And that's where I refer out to somebody like these two women we have here to help them get that control of the mast cells, because that pain and inflammation cycle can't stop even if you've stabilized to the ends.
Yeah, I think a lot of people think of the connective tissue as just purely structural and mechanical, which of course it's a very important role of it, but it's a very dynamic physiologic organ, and a lot takes place within the connective tissue, specifically immune activity, both innate and adaptive immune activity. So it really has a great role in how our body overall responds and how inflamed our body is. And some of the mediators that are released from the mast cells are proteases that actually target collagen and break down collagen even further. And so it just creates a whole set of like disarray that goes on within the connective tissue, which is literally all over our body. And it's important because it's meant to keep an appropriate alignment of our organ systems, right? So every organ system is actually genetically predetermined about where it should be in the body, and specifically the ratio of where it is in relation to another organ system. And if that is not held in alignment and is slightly off, then the cellular signaling that takes place, which is sort of how our body works, right? There's lots of communication, and both Valerie and Anne referred to this communication and how critical it is. But if a tissue or a cell is not where it's supposed to be, that signaling is not as loud, it's not as clear, and it's not as received as well. And so that's where symptoms start to develop, and that's where, and it can take a long time before true disease or disorder, but over time, that is exactly what will happen if we don't recognize the role of the connective tissue and what takes place within it. It is a dynamic organ, and the spine, we think about obviously hypermobility, we think about, the knees, the hips, the shoulders, and so on. But there are so many spinal manifestations. And when you think about the neural tissue, which is very compressible, so the brain and the cord, and all that takes place within those neural pathways, including communication with the autonomic nervous system and the peripheral nervous system, you can start to see why there are so many symptoms in these chronic fatigue syndrome kinds of patients in this post-infectious world. So, again, it's a lot of anatomy, a lot of physiology, and I don't think we have the time to go into all the details, but I think the three of us, I think that it was a good synopsis and a good overall generalized statement about how important the connective tissue is and how it interplays with the mast cell activation and the dysautonomia and so on.
I have a question for you all about testing, because I think that a lot of students will be like, okay, well, if I do figure that it's going to be that there is some issue at play that needs to be investigated, besides asking questions and getting answers, can I order a test? What tests are available? Or are there any tests?
I really think testing should follow taking a really good story. And then you can then do targeted testing. And unfortunately, Lord Kelvin's statement about if you can measure it, you can change it has been bastardized to if you can measure it, if you can't measure it, the patient is crazy. So I really think, and also not one of these systems is a one-trick pony. So if you think the mast cell is only responsible for you having reaction to peanuts or mosquitoes, you're sorely mistaken, and that will lead to you taking more and more medications that control one component of these cells that are found in every single human being. Like, there's not a single report of a patient lacking mast cell. So the question is whether those mast cells are behaving appropriately or quote unquote misbehaving. And I can say the same thing about the connective tissue. There's a range of phenotypes and endotypes as well as the nervous system. And I really think when it comes to general practitioners, because by the time they get to our areas of expertise, these patients are in the hands of general practitioners much longer. So, for instance, 7% of the pediatric population is hypermobile. We also know that hypermobility is associated with increased risk for mood disorders or POTS. So why not, or if you're going to screen a child and identify that they have scoliosis, just don't say scoliosis and then keep rolling. I think taking a detailed assessment and having a screening questionnaire first, then you can do some basic screening tests. But if the test is negative, especially when it comes, the frustration for people all the time, they're like, well, they told me that tryptase is normal. I'm like, as far as I know, I don't know that there is a normal tryptase level. So let's go back to the chalkboard and try to figure this out. But I'll defer to Eileen and Valerie regarding, I really think we need to go back and learn how to take a really good story, try to identify some early, red flags to say, okay, now we need to ask another different set of questions. And then based on those questions, this is the type of testing that we can order.
I completely agree. The more you ask, the more you find. And I think that unfortunately, healthcare doesn't give doctors a whole lot of time. So some of it is, in defense of doctors in general, that they just don't have a lot of time to take the kind of comprehensive history that these patients really do require. Because when you start asking enough questions, you do find those red flags, and they usually are back in childhood.
I agree with the importance of the history for sure. And when it comes to hypermobility specifically, I'm using more than just the bite and the screen for that. I'm using a couple special tests. I know from treating this and from having this that most of the issues aren't going to be in a lot of the joints that the bite and score tests for. So I'm going to look at the shoulders and I'll move their femoral head back and forth and assess how much motion that has to really gauge where on the spectrum they lie if this joint's involved. But that's the load and shift test. I'll do the Solke sign where I pull it down and assess the gapping that they get there. A hip dial test to assess the laxity in the hip, their patellar mobility and that translation. That way we're not blocked if they have bony congruency that's blocking them from some of these tests of scoring more highly, so they don't show that hyperextension at the knee. You can assess other ways to make sure you're really looking at the whole patient, not just the standardized bite and score, that's it, end of story. So, taking a look at the hypermobility of the feet and the ankle, all of these things are important as well.
That's incredible. And that's the beauty of being a physical therapist. That's what we need for our patients is you.
Valerie, you're getting 4 calls, my friend. But also, I would also lean into the fact that we also, as Western allopathic trained physicians, have a tendency not to look at other modes of evaluation. And for instance, unlike the U.S., the French have had a standalone EDS clinic for over a decade, and they have a screening questionnaire just based on the very long medical history that most of these patients have. And they've shown that if you, out of the 9 questions, fairly straightforward 9 questions, if you have 5 positive questions, you have over a 98% specificity and sensitivity of having a heritable disorder of connective tissue. So again, just asking 9 questions, you can then identify whether or not somebody has the risk of having a connective tissue issue. And if you recognize that they have a connective tissue issue, then you should just pivot to say, well, would you have any issues with your nervous system? Oh, by the way, do you have any issues with your immune system? And again, I have to tell you, I would have to say 70% of the patients that I see acclimate down to the amount of pain that they deal with on a daily basis, on the amount of inability to take a deep breath, the fact that they're sleep deprived, and all of these things are leading to negative allostatic changes regarding how their body has the resources just to do simple activities like take a breath. So I would pivot to, I think, rather than saying, please order a tryptase test or please order a sensory and motor autonomic neuropathy panel, or I know about that. I've been shown it a couple of times. I don't trust my judgment, so I rather give a questionnaire, like and just to let you know, from an immunology standpoint, asthma is a common chronic condition. Yet pediatricians, internists, OBGYN, nobody screens for this disease. So essentially, we don't diagnose somebody until they have an attack that lands them in the emergency department or worse. That's like telling somebody, oh, by the way, you have hypertension after they have a heart attack. Why don't we just ask why don't we just have a very easy questionnaire that can be completed by the patient before they see the practitioner? And if they check one positive box, like, did you do funny tricks when you were a kid? If you check one of those, then you should be formally screened. And the screen isn't a definitive diagnosis. It just says, okay, you have signs and symptoms here that are worrisome for something that might be explaining what's going on with you. Now I need to take this a little bit further. And if I can't do it, let me send you to one of my good colleagues who I know will be able to run with this baton after we toss it to them.
That message has resonated across episodes time and time again. Practitioners saying, listen to your patients, listen to your patients, listen to your patients. Every single episode, that has been the message. And so, I mean, it's very clear that that's what's needed. And
Yeah,
I'm
and
hearing that there's
important.
also...
Yeah, sorry.
No, go ahead. Go
No,
ahead.
I was going to say that. And Anne referred to this earlier in the episode where medicine is so siloed. And so many specialists just sort of like to sit in their box. And, you know, as neurologists, we love to localize. And very few of these patients with their chronic illness and their chronic symptoms and their diverse array of symptoms really do localize. And it's because this is a systemic problem. And when you think about the connective tissue, it is not just about the joints, of course, right? We have specialized connective tissue, the blood, the lymph. We have connective tissue that, you know, lines all of our, hollow organs. It lines the GI tract, the respiratory tract. It's the meninges, right? It lines the vessels. So connective tissue is just so ubiquitous in the body that, of course, things that are related to connective tissue are not going to easily localize. And so that's where a lot of, I think, patients, and I can only speak from the neurology world, of course, sort of get lost when they go see a neurologist because they have clear neurologic symptoms, and certainly their PCP has told them that and has referred them to neurology. But, you know, oftentimes EMGs are normal. The imaging, you know, is within normal limits. So it can be very hard for these patients to convince, you know, doctors and specialists that something really is going wrong, which I think is why those of us that work with this patient population say, listen to your patient. They know their bodies better than we do, right? So maybe that's why this has resonated with every episode, because that is such an important point.
To build off of that, something that I get asked a lot is, what's the value of getting a diagnosis if there's no cure for these hypermobile conditions? And I think that ties a lot to what we're talking about in this conversation of listening to your patients and everything, because sure, there's not a cure for hypermobility. There's not a cure for hypermobile Ehlers-Danlos syndrome or any of the Ehlers-Danlos syndromes for that matter. And there's far more connective tissue disorders than what I'm listing here. But there is management. First of all, that's my job as a PT. But the other part of this that's so important, and where I think diagnosing really helps a patient with their management, well, in two main ways. First of all, mental health, validation. Eileen, what you were saying about, does your head feel like a bobblehead earlier in the episode, or asking, like, reusing some of that language back to the patient is such a validating experience of, I feel like that. I can't believe they're using this language. I must not be making this up. It's an incredible feeling for a patient to feel that way. But they would never get to you if they didn't have someone to point you there, right? And so if someone has hypermobility, then it's a plausible factor to consider that they might have craniocervical instability or some of those other neurologic conditions that we've been talking about. But if they didn't have this hypermobility, nobody's going to be sending them to get instability screening in their neck if they haven't been in a car accident or something. You can see hypermobility. You can't see mast cell activation syndrome. And I'll leave it to you, Anne, to speak about all of the complexities that it is. It's not just being allergic to something. It's so much bigger than that.
I would, just pivot back to your allergic to breathing. That just translates to me like you're having problems breathing when you lie down. So, so now so let's break it down, not by individual diagnoses. It's like, is your airway becoming swollen, or is it your neck is moving, the spine is moving and pushing up against the airway so that you feel that sensation, or maybe it's not here, maybe it's further down, and you might be having diaphragmatic spasms or rib subluxations that are just interfering with you to take a big breath. There's lots of different ways that people can have problems breathing, and I think, again, if you just think about it, is why would somebody who was working and living their good life want to spend all this time coming into my office to I mean, literally, I think as Francis Peabody mentioned back in 1927, only the poor, person who's living on the street really wants to spend their time in an emergency department or use all their ducats to come see any of us, as opposed to enjoy their family and enjoy their lives outside of the doctor's office. And the fact that we go after, a lot of practitioners, and I agree with Eileen when she mentioned that the healthcare system really does not allow a lot of the providers and practitioners to go past 3 minutes. That's the cutoff. 3 minutes, and then they're like, okay, now I need to come up with something that I can code to justify the time I just spent with you, so my RVUs are met, or my threshold for bonus is met. And unfortunately, again, I think we've got away from having a relationship to a transactional existence between patients and their healthcare providers. And so I think, again, not only giving them the time, but also giving them kind of like an outline on how to tell their story. And patients shouldn't be scared. I mean, practitioners shouldn't be scared that every single system on the review systems has been checked, because this is what people have been dealing with. It's not as though they want to. And I think, one of my favorite phrases from medical school was from a retired rheumatologist who basically said, each and every one of us needs to be on the other side of the bedpan once, and some of you SOBs twice. If that practitioner, honestly, you really need to kind of treat a practitioner like you're going to a restaurant. If that person is not listening to you, then just smile, wave, give them their copay, and move on. And by the way, there are a lot of good patient organizations in the Ehlers-Danlos world, in the autonomic neuropathy world, and then the mast cell immune dysfunction world that will give, those are ready links that I think patients can use to try to identify practitioners that are a little bit more sympathetic to listening and empathetic to listening to the story, and then being able to do something about that story once they're giving the patients the opportunity to share their tale.
Thank you, everyone. I'd like to address anything that you feel is important that we haven't had the opportunity to speak about, because we have a little time left, but I want to make sure that we bring any value to the students that you think we might be missing.
I don't think we have enough time.
Take a breath. Take a breath. Take a breath. We're all learning. We're all learning.
True. We still learn every day. I mean, all of us.
We're still learning.
I know.
We're still learning.
Patients teach me more than, I think medical school taught me a lot, obviously, and laid the groundwork for me, for sure. And residency added to that. But I have learned from patients every single day, and I just add to my knowledge from the work that I do. And so just know that the learning never ends. CME is not always in the form of conferences and articles and webinars. It's in real life experiences where the CME, and you don't necessarily get credit for the CME, I should add, but the CME does exist with real life experience, with practicing medicine, practicing your specialty, seeing patients, talking to patients. It is so important, and neurology, as with other specialties, is complex. And the more you listen, the more you ask, the more you read, the more you realize, wow, there's a lot here, and there's things that we can do. There are things that we can do to help patients, for sure.
I agree. The most you learn is from your patients and listening to them, and like we've been talking about all episode here. And so I think that's how you truly become the expert in a field, is by having the experience of trusting what your patients are saying and having a little bit of the confidence and the trust to know we're going to try a couple things and we're going to see what works for you, and having the patient be on board and having that two-way trust that we talked about before, where the patient trusts you, but you trust the patient too. And that really opens the door for some of the creativity that's really going to be the movements of innovation of the healthcare field.
And not only patients, honestly, if it wasn't for mast cell dysfunction, I don't think Valerie or Eileen, we would have met.
True.
Like, I really think I'm a believer that our steps are ordered. And it's a question of you trusting yourself. You're really trying to do the best for that patient, the best you can. And you can say, I don't know, and then give the patient the opportunity to work with that information. But just because I say I don't know, doesn't necessarily mean I'm not going to stop trying. And I can tell you, and Eileen and Valerie, you probably could comment, what I know about mast cells now is infinitely far from what I had to relearn almost a decade ago. And it's evolving now. Like, even now, the relationship between the nervous system, the mast cells, and the connective tissue has just been reordered just within the past couple of years. So we have to learn not to hold on to things that were published, 10 years ago. It's a good skeleton, but you have the ability to brush a broader, more colorful palette. And I'm a big fan of Color Your Doctor to let them know.
You have to be willing to be wrong. You have to be willing to be corrected. And you have to have an open mind. That's what I say to myself every day, when I go to work with patients. I'm always willing to be wrong. I'm always willing to be corrected. And I always have an open mind.
And what's neat is that we're all saying this, and we're in such different interdisciplinary fields, that tie together, disciplinary fields that become interdisciplinary fields. And, it's things that, like in the physical therapy world, I've learned you need to assess these patients for subluxations before you can have them exercise. You have people who just keep exercising, they're putting all their work in, they're getting so strong, and they're not having success. But if you're not checking for some of these subluxations before they exercise, then it's going to lead to them exercising with these joints out of place. That'll orchestrate this poor length-tension relationship of the muscles, or the muscles being minorly displaced by the subluxation. And these aren't things you learn in school. These are things that you learn with exactly what we're talking about. And I just think it's really cool to watch how we each do that differently in our fields too, with the same population.
Well, thank you, everyone. This has been an incredibly enlightening and wholesome conversation, I would say. It's just really important that there are people like you in your positions doing the work that you do, because you are making the change that needs to be made to move the practice forward and to help us eliminate these issues for these patients. So I, as a patient, I commend you. As an educator, thank you for your time in helping us teach the next generation of medical students. And I appreciate your time.
Well, thank you.
And we appreciate you and the efforts that you bring to teach what you've learned on both sides. And also, I appreciate the fact that out of all the training institutions I've been to, I found that the Icahn School of Medicine has been the most dedicated to thinking about innovative approaches to new and old problems.
Yes, I agree.
Thank you so much, Raven. This has been awesome.
Yeah, Raven, thank you for all the good work that you're doing.
Of course, I couldn't do it without you. You're the experts. Well, thank you, everyone, for listening. And we hope that you learned a lot. And stay tuned for the next episode. Bye.